Okay, hello everyone. Welcome to a very exciting subspecialty rheumatology virtual morning report. My name is Madalena and I will be facilitating today's discussion. I'm a medical student in New York City, just finished up my third year of medical school. So as I mentioned, this is a rheumatology focused VMR and we have two very special guests. So our specialist discussant is Dr. Mike Putman. He is a rheumatologist at the Medical College of Wisconsin. He is the Associate Fellowship Program Director and Medical Director of the Medical College Wisconsin Vasculitis Program. And he's also the host of the Evidence-Based Rheumatology podcast. So Dr. Putman, welcome. I would love it if you could share a little bit about yourself and then also the inspiration behind starting the podcast.
Yeah, absolutely. Thanks so much for having me. It's an honor to be here. So I'm a rheumatologist. I live in Wisconsin, like you said. I've got 3 kids. I started the podcast because I really like evidence-based medicine, and I was trying to find a podcast that talked about evidence-based medicine rheumatology, and there was none that were doing exactly what I wanted to hear, and I said, I'll just give it a whirl. My first 10 episodes or so were pretty terrible. But eventually you kind of get into the swing of things and buy a microphone that's not terrible and kind of figure out what you want to do and what you want to accomplish with it. And so yeah, no, it's been great ever since then, kind of cruising.
Amazing, I love that. And do you have any hobbies that you want to share that you have outside of medicine?
Yeah, I have so many hobbies. Most of my life is devoted to hobbies. I do a lot of construction. I have done a lot of remodeling my own house. I enjoy knitting. I'm really into cocktail making lately. That's been kind of like a big passion of mine. This last couple months, I've been trying to become a mixologist of some variety. I think if I'm not like actively trying to generate a new hobby, I become sad. So that's one of the major things I do in life, actually.
Those are incredible hobbies. Wow. Well, that's fantastic. So our case presenter today is Sharanya Kaushik, and she is a final year medical student at Bangalore Medical College. And Sharanya, we would love it if you could unmute and share something about yourself that you like to do outside of medicine.
Hi. So currently, besides studying, I've been reading a bunch of nonfiction. I'm reading Skin in the Game by Nassim Taleb. And I also hike when I get the time, and I design or like paint as well.
I love those hobbies. What's your favorite nonfiction book? I'm always looking for recommendations.
That's difficult. I mean, it depends on the genre, but I think right now I'm really enjoying the book I'm reading, Skin in the Game, but I haven't gotten through it. I also like Outliers by, what's his name?
Malcolm Gladwell.
Malcolm Gladwell, yeah. Thank you. Yeah.
Wonderful. Well, thank you so much for presenting the case today. And last but definitely not least, we have Sammy and Kiara who will be doing scribing and teaching points. We can start with Sammy. Sammy, can you unmute and share something about yourself?
Sure. Hi, I'm Sammy. I'm a last year medical student from Austria, and I'm currently in Kansas City doing like a clinical rotation. And I spent the weekend with a friend. We like rented a car and went to a lake, went swimming. Yesterday I got to watch the new Jurassic World film. I'm a huge fan of it. And yeah, it was really nice. And so glad to be here with you all. And I really like rheumatology, so I think this will be really great. Thanks for being here, everyone.
It is the best specialty after all.
I'm sure we will all be convinced of that by the end of this session today.
Yeah, I'll be my best.
And Kiara, would you like to introduce yourself and share something about yourself outside of medicine?
Yes, of course. So I'm Kiara. It's been a while since I joined, but okay. So I graduated last year from med school. I love internal medicine. Right now I'm working, studying. I will taking the OET exam, I think tomorrow in 2 days. I'm kind of nervous. And after that, the CK in September. What I like to do, I like swimming. I swim like 3 times a week, I'm sorry. And I have a dog, which I love, and I can show you. He's like sleeping, he loves sleeping.
Oh my gosh. What's the dog's name?
His name's Zach, like Zach Efron, Zachary, I don't know. But yeah, he's amazing. I love him. So yeah, right now it's between studying and working.
Yes, definitely. I think we all understand that. Well, good luck on the exams, Kiara.
Yeah, thank you.
Okay, so I think we can jump into the case today. So the scribe can share their screen, and Sharanya, you can go for it.
Okay, all right. So the chief complaint is sudden onset of weakness in all four limbs. And the history goes as follows. A 25-year-old female presents with sudden onset of weakness of all four limbs, which started about 12 hours prior to arriving at the hospital. This has been rapid and progressive. And she was initially taken to a hospital close to her house, which then referred her to our institution in view of a suspected cerebrovascular accident. So on further questioning, she says that she's had generalized fatigue for the past 2 months.
When do I jump in? I don't know. I should ask questions. Just tell me when to start talking.
Okay, I'll just finish the negative history. Okay, so she reports no history of syncope, headache, gastrointestinal symptoms, urinary symptoms, also no history of joint pain, rashes. There's also no history of fever or weight loss. So that's the history part. Should I move on to past medical history?
Sharanya, you can actually pause here, and I would love to get
Okay.
Dr. Putnam your initial thoughts on this. How are you thinking about a differential and an approach to sudden onset weakness with this history?
Yeah, I gotta say, my first impression is that it's not rheumatic. I gotta say. So here's my framing for that. I think you should always start with a good problem representation, and a problem representation should include, some salient factors like epidemiology. So like for one, the patient's 25, so she's on the younger side. This is very peculiar for someone who's 25. And then it's acute. And as a general rule, rheumatic diseases and autoimmune diseases tend not to be acute. They tend to be indolent. And so when patients come to me with weakness, I try and take a systems-based approach to how I think about weakness, right? And so the first thing is this proximal or distal? So proximal weakness tends to make you think about idiopathic inflammatory myopathies. So dermatomyositis. Polymyositis doesn't exist. That's a whole different podcast. Or one of the other idiopathic myopathies, right? So, but those tend to be indolent, slow onset, very proximal, shoulders, hips. And so I doubt that it's that. Now, so when you hear extremities, she said all four extremities. So she could mean distal. So is she talking about her hands and feet? If she's talking about her hands and feet, you can think of some peripheral etiologies for that. The really only thing that would work for in the rheumatic disease area would be something that affects the large nerves, specifically axonal demyelinating processes. And so there's this entity that we don't talk about very much when you think about nerve diseases from autoimmune disease. You think about mononeuritis multiplex, which is a demyelinating axonal neuropathy. It tends to be, we call it mononeuritis because it affects one limb, but that said, it can affect multiple. And so in particular, people with eosinophilic granulomatosis with polyangiitis, EGPA or Churg-Strauss, people with that disease can have a polymononeuritis where that hits all four limbs, but it tends to be very patchy, tends to be indolent, and it tends to be asymmetric. So this doesn't feel right for that either. You can also see that in microscopic polyangiitis, but also just not the right presentation. So, whenever you hear someone with weakness in all four extremities, if you're not, and it's acute, you're probably not really in the peripheral nerve zone, right? Because peripheral neuropathies tend to come on over the course of days, weeks, months, really. So coming on over days would be sort of atypical. And so I would kind of move up the chain and say, all right, so if it's not a peripheral neuropathy, are we more worried about a central lesion? And, in particular, I mean, all 4 extremities without other like cranial nerve symptoms or signs of a stroke, which would be extremely strange in a 25-year-old, really makes you think about the spinal cord, right? And to affect all 4 limbs, it's going to be a high lesion. So something like transverse myelitis in a patient with lupus, all of a sudden you kind of have the right epidemiology and you actually have a lesion that could account for the weakness in all 4 limbs. Or of course, some sort of intracerebral accident that just hit the right locations. But truthfully, stroke symptoms, CNS vasculitis, clots, those things tend to be asymmetric as well. It's hard to infarct all the motor regions of your hands and feet symmetrically from something in the brain. So, I hear this case, the main thing that I'd be worried about would be transverse myelitis in a 25-year-old patient with lupus. But there's a lot of things outside of that you can consider. So acuity, you could think of an acute myopathy. So like rhabdomyolysis could look like that, although we usually have some sort of preceding history, some sort of exposure that would kind of key you into that direction, or some sort of toxic exposure. So really the truth of this is that you have to really ask a lot more about what she means by weakness. Is she just tired? Or is she like literally unable to raise her hands and feet? And right now we don't have quite enough history to say. And I think once we get more information, especially a physical exam, we'll be able to kind of narrow down to where we think the weakness is coming from.
That was awesome. Dr. Putnam, I loved how you first started with the problem representation, which for me is just such a helpful way to think through cases, and that you kind of systematically broke the differentials into the time course. So the acute, subacute, chronic, and then also kind of the anatomic approach. Is a peripheral nerve or more of a central issue? So that was really phenomenal.
I built those schema.
Yeah, exactly. I'm curious, when you said that you really need to understand what they mean by weakness, what types of questions would you generally ask the patient to clarify that?
Yeah, that's a great question. And so this is, so clarifying questions are very important. I always let people talk because you want to hear their whole story. But then part of the art of internal medicine and rheumatology is really honing on what people are actually saying. So when someone says they're dizzy, is that vertigo? Is that pre-syncope? Like, what do they mean by dizzy, right? And so a lot of these colloquial words, you need to translate them into a medical vernacular so you can actually structure your approach, right? And so people say weakness, they mean a bunch of different things. They tend not to mean sleepy, but they can mean fatigued. So, any disease can cause that. It's completely non-specific, right? And so if we're dealing with fatigue, we have a lot of work to do here. But then when people mean weak, they can mean that they have a trouble with strength. And so that can be sort of a process where, like you used to be able to raise your hands above your head, but now you can't do that. Or, it's hard to comb your hair. Things like that, like these sort of behavioral things that would mean that their strength is just a little reduced. So that's one thing they mean by weakness. Another thing they mean is that stuff just doesn't work. Like they can't raise their feet up from the ground. And that's a totally different thing, where the former is more muscles and more of a myopathy. The latter is much more neurologic. And so I would say, what do you mean by weakness? Do you have trouble getting out of a chair? Are you stumbling? Is it hard to get out of bed in the morning? Like, what exactly is weakness to you, or what's your experience of weakness? And you'll pretty quickly hone in on what they're actually saying by just a few clarifying questions.
Awesome. Okay, Sharanya, do you want to give us more information?
Yeah. So to clarify on weakness, she isn't able to walk or lift her hands up. Like she's not able to use her limbs. She can't hold anything. She can't lift her arms. She can't walk or lift her legs. So that's weakness. And so past medical history, she does give a history of a similar episode 5 months ago when she was taken to a local hospital. She doesn't have the details of why the episode happened or how she was treated, but she said that she was given IV medications and fluids, after which it resolved. So
what happened 5 months ago?
She had a similar episode where she had weakness of all 4 limbs, but she doesn't have the details of it. And she just knows that she was treated with IV fluids and medications, and that helped resolve the symptoms. But yeah, there are no other details of the episode. She also had an episode of anemia 2 years ago requiring B12 injections, but she didn't complete the course.
So this is weird, right? So anyone who has weakness in all four extremities acutely, episodic, it's very strange. So I'm obviously focusing on neurologic things, but you would think outside of that. So like chronic inflammatory demyelinating polyneuropathy can cause a presentation kind of like this, again, more indolent. You'd think about Guillain-Barré syndrome, especially as ascending in the legs, but I mean, it's weird in the hands and legs could happen. But you're really in a strange, very strange set of things. She has, can I ask a couple clarifying questions? So when she says her legs are weak, what can't she do? Or am I jumping ahead to the physical exam already?
Oh, she can't walk, she can't lift them.
Oh, is it
yeah,
the flexors
like
or is it?
paralysis.
Yeah.
No, everything. It's the flexors and extensors. Yeah, and it's not proximal or distal. It's generalized.
The whole shebang.
Yeah.
Yeah. So this is bad. And again, so it's hard to imagine a peripheral process that would happen acutely like this. And so I really think I'm in the spinal cord because you have to somehow affect all of the motor, all the neuron pathways that go to the arms and to the legs simultaneously, quickly. And it's just hard to do that with a peripheral neuropathy. It's hard to do that with an idiopathic inflammatory neuropathy. You really are inflammatory lesions in the spinal cord when you see something like this. And they're high. Like we're talking like C6 or something weird like that, you know, like a high spinal cord lesion. All right. Interesting. Okay. I'm excited. This is a weird one. You don't see this kind of stuff very often. How's her bladder? Is her bladder functioning?
Should I say it now? Yeah, her bowel and bladder is fine.
Weird. Is she having sensory symptoms as well?
No.
Oh man, that's a weird. All right, I'm back to CIDP. All right, let's keep rocking.
All right. So medication history, she's not on any medications, and there's also no family history of autoimmune diseases or stroke or myocardial infarction or coagulation disorders. And there is no history of travel or contact with sick people. She uses alcohol occasionally, but there's no smoking or drug use, no known allergies. So on examination, her vitals are 98. Sorry, her temperature is 98. Her heart rate is 54. Her respiratory rate is 18. And SpO2 is 98. So just on general examination, she has conjunctival pallor and a left cheek swelling is noted. There is also no lymphadenopathy and no rashes. And so cardiac exam, there are no murmurs, S1 and S2 are normal. The chest is clear. The abdomen is soft, non-tender, and no hepatosplenomegaly. So the neuro exam. So the power in all four limbs is 1/5. That's left cheek swelling. And the neck is hypotonic. And DTRs are absent. Hypotonic neck. So that was motor system examination. Sensory examination is normal. Bowel and bladder functions are normal. Should I stop here?
Yeah, you can stop here. Michael, Dr. Putnam, I'd love to hear what you think of this physical exam and how that's affecting your differential.
Yeah, I still don't think it's rheumatic, but I mean, I think that this kind of confirms our history, right? It confirms how serious this is. This is kind of scary. Like a 25-year-old with 1 out of 5 strength everywhere. It's very peculiar. so you can see, again, is this distal and proximal?
Yeah, it's distal and proximal, yeah.
Distal and proximal. So, I mean, it's not an idiopathic myopathy because you would not get that diffuse disease. So something's affecting the nervous system. I don't think it's a stroke. It'd be hard to get a stroke that's symmetric on all of these extremities. So you're in the spinal cord or you're some sort of really aggressive demyelinating polyneuropathy. So yeah, I mean, I'm in the same realm as before. This person needs a very aggressive workup very quickly. That's all I can say.
And Daniela actually mentioned in the chat, she said, Dr. Putman, can you elaborate on how a lesion in the spinal cord could present like this? I'm struggling to try to understand how it wouldn't affect movement completely with your current hypothesis of transverse myelitis. So if we are localizing to the spinal cord, what pathologic processes are you thinking of?
Yeah, so again, I mean, this is a weird presentation. I don't treat peripheral neuropathies, so I'm outside of my game on that. If you have a peripheral neuropathy, it tends not to be this fast. That's the problem with this case is you don't just like walk around one day and then the next morning wake up and not be able to move because you've lost all your myelin sheath, And so it's just really hard for me to imagine that fast of a peripheral neuropathy. Over weeks, you can lose that much. So like CIDP, some of these diseases, you can really lose a lot of neuropathy, a lot of stuff really quickly. And then in the central nervous system, like in the brain, it's hard to develop this much symmetric weakness. And so your motor pathways converge in the spinal cord, right? And transverse myelitis isn't transverse, it's actually longitudinal. And it also isn't a total lesion. So a lot of people with transverse myelitis will retain some function. So it's not like you cut the spinal cord, so you develop inflammation in the spinal cord. It would be weird to be this selective and in this much of a motor distribution, but I mean, that's like just trying to think about this from an anatomic perspective, right? This is diffuse and it is acute and it is symmetric. And that's just weird. Like it's hard to put that up in the brain and it's hard to put that in the peripheral nerves because either it would be more indolent or it would be less symmetric. And so I don't know, even transverse myelitis is often not totally symmetrical either though. So it's like, this is just a weird case. I'm kind of excited to see where it goes. And again, you're gonna do a lot of workup on this patient. You're gonna do imaging for sure, CTL, and you wanna get an EMG really quickly to find out what the heck is going on in those neurons. There's probably some other stuff as well, but that's probably where your money is gonna be is imaging and figuring out what's happening in those nerves.
Yeah. Is there any specific lab work that you would you would definitely want to make sure you didn't miss?
Yeah, I mean basics, CBC, CMP, of course. I'd check inflammatory markers like NEOSR, CRP, but it's low value. You're not going to get a lot from that. I would check an ANA with reflex. So we have an ANA panel that sends an ANA. I'd get the HEP2, so you actually get the immunofluorescence titers, and then it reflexes to like Smith and double strand and all that jazz complements. I would send that as well. Someone mentioned NMO, I guess. You worry about infections. I mean, I guess, I don't know if this patient deserves an LP. You see what you find on the imaging. That'd be like the next step if your imaging is a big whiff or if it's kind of bizarre. And I think that's probably where I'd start. I would send a CK and an aldolase, but I don't think it'll be very helpful. And I would not send a myositis panel at this point. It's expensive. It's a send out, doesn't come back for a while. And you'll get a lot more money or a lot more bang for your buck from just getting an EMG. Chest X-ray is not going to help you here, I don't think. EKG is probably not going to help you either, I don't think.
Okay, I'm also on the edge of my seat. So Sharanya, what other details do you have?
Yeah, what happens next?
All right. So labs, the hemoglobin was 9.6 and leukocytes were 8,400 with 65% neutrophils and 30% lymphocytes. And ESR was 74. And then AST was 20. ESR was 74, erythrocyte sedimentation. Yeah. AST was 20, ALT was 34, ALP was 70. And creatinine was 0.9 and urea was 32. All right. So sodium was 146. Potassium was 1.4. And chloride was 120. Bicarb was 16.
Low case.
Calcium was 10.4. All right. And an ECG was done, and there was sinus bradycardia, delayed interventricular conduction, and U waves. And so on urine examination, pH was 6.3. So urine sodium was 70, urine potassium was 34, urine chloride was 54. There was no blood or protein. And USG abdomen was normal. Urine potassium was 34. Yeah, I guess I'll stop here.
Wow. Okay, Dr. Putman, what are you thinking with all this data?
I mean, this is a debacle. That might be the lowest potassium I've ever seen. She has no other symptoms, like she's not, having horrible vomiting or diarrhea and anything like that. Kidney's just chilling and happy. Someone mentioned an RTA.
Oh, yeah.
And that's it. What's that?
I'm sorry.
What's that? Someone mentioned an RTA.
Sorry, that was a mistake.
So the potassium is definitely 1.4, correct? That's extremely low. So there's a lot going on that is kind of unexpected. Her liver is happy. She has a lot of electrolyte abnormalities, and in particular, her potassium is extraordinarily low. It's very bizarre in someone like this. So, you obviously worry about her kidneys, worried about her heart with the potassium that low. So you want to get that repleted pretty quickly. The EKG abnormalities, I mean, it's hard to perseverate on that too much with these profound electrolyte abnormalities. So I imagine a lot of that will improve if you can get her doing better. And then, yeah, I mean, someone mentioned RTA. That's a reasonable idea. I'd be curious to see what your next steps are and what else you find.
Okay, so we ordered an ANA. So the title was
She hasn't taken anything weird in, right? There's no like weird ingestions. She's not like eating Tide Pods or something bizarre like that. Not that we know.
As far as the history goes.
Okay,
yeah.
Just making sure.
Can Tide Pods present this way?
I don't think so.
I'm not
This
sure.
is just a weird one. What's her? If
Okay.
we have a magnesium somewhere, we should get a mag as well while you're at it.
Oh yeah. I don't think I noted that down. Sorry.
You're good. I would send it.
Okay. So ANA was 1:1860. Rheumatoid factor was negative.
I was joking about the Tide Pods for the chat. Yeah.
Anti-dsDNA was negative. Anti-Smith's antibodies were negative. Anti-LA was negative, and anti-U1RNP was negative. Anti-Rho slash SSA was, anti-Rho SSA 52 was 280, and SSA 60 was 150.
So I'm not familiar with these particular reads. So this is an SSA is positive. And what was the ANA?
Yeah, it was positive. Yeah. ANA was strongly positive, and SSA was also positive.
So when you see a positive SSA, where is your mind going in terms of thinking through the differential?
I mean, I'm kind of underwhelmed by it, to be totally honest. So I mean, the SSA antibody, you see that with Sjogren's syndrome, which can cause an RTA. So that could bring everything together. It's uncommon. This would be a very bizarre presentation of Sjogren's syndrome, and just not something you should be thinking about when you see a patient like this. But you know, you think about Sjogren's syndrome, there's a surprisingly high rate of positivity in idiopathic inflammatory myopathies, but I'm still like not buying that for this case. And then the other things that most of them are just incidental and bogus. I don't know what that is on your, like we have a titer, and so like I have a sense in my lab greater than 8 is pretty high and suggestive, but and you know, you want to know what the ANA titer is too. Like an SSA with a normal-ish ANA doesn't mean much to me. It's mostly artifactual. So yeah, it kind of depends on the particulars. And truthfully, I don't get too jazzed up for these guys, but yeah, it'd be a good place to start.
All right. So we also did a Schirmer's test, and it was like 5 centimeters, which was reduced your production. So a presumptive diagnosis of Sjogren's syndrome was made, presenting as distal RTA.
Does she have dry eyes or dry mouth?
She didn't provide any history of it, but like on a lot of probing, she did admit to like having dry mouth occasionally, but it wasn't something significant that.
Yeah,
It didn't come up.
Yeah, be careful though. I don't do Schirmer's tests actually. I don't really believe in them. I think it's quite silly. I think there's a big movement to quantify everything, and I don't find it terribly helpful for Sjogren's syndrome. Sjogren's syndrome, the question is like, does this affect your quality of life? The truth is there's like not much to do for like 95% of people with Sjogren's syndrome. So I actually don't do a ton of quantitative testing. Would I go for a lip biopsy? Great question. I might actually. The RTA is quite peculiar. You can see that in Sjogren's for sure, but it's just such a rare presentation of Sjogren's syndrome. And whenever you have like a rare presentation of a rare disease, you should always take a step back and be like, okay, I've never seen, you know, I've seen a lot of Sjogren's and never in my life have I seen this presentation of it, you know? And so you always say like, is there something else that's going on? I haven't done a lip biopsy in a long time. And the reason is the same reason that I don't do a ton of quantitative testing. And that's that there's nothing to do for most Sjogren's. There's really not a lot to do. And so the diagnosis of Sjogren's syndrome doesn't meaningfully impact how you're going to treat most patients. There are exceptions. So I screen for rheumatoid factor, I screen for cryos. And if there's any breathing symptoms, I screen for interstitial lung diseases and cardiac involvement. I'll get pulmonary function testing as well. So I do a lot of screening of those things because those will impact management. But a lip biopsy and like a stronger, more certain diagnosis of Sjogren's tends not to. And lip biopsies are not benign. People can have persistent numbness at the site and they can have scarring. It can actually be quite, I've had more people complain about lip biopsies and have it really affect their quality of life negatively than I've had it like meaningfully improve anything for them. So I haven't done a lip biopsy in over a year or two, actually. Yeah, good question.
So I'm curious, as you say, this is clearly a very, atypical presentation of a rare disease, but just for, the learning of myself and for everyone on this call, in your experience, what is the more typical, presentation of Sjogren's and kind of the workup that you generally use?
Yeah, I mean, 95% of Sjogren's presents with Sicca syndrome, so dry eyes, dry mouth, some fatigue, and maybe some joint pains. That's like 95% of Sjogren's. And most of those people don't have anything else. That's just kind of like where they are. And there's literally nothing to do for it. I mean, I'm overstating the case a little bit. You can try pilocarpine to try and improve salivary flow. Works a bit. There's some RCTs to support it. And so I'll offer it to patients. has a lot of side effects. At least half the patients I try it in say that it was a net negative in their life and they stop it. There's a large cohort of people who will give these folks hydroxychloroquine. That's remarkably unsupported by data. So I keep meaning to write this editorial. It's going to be called "The Joke's on Us." And that's a reference to this RCT that occurred in Sjogren's syndrome called the Joker trial, spelled JOCQUER. It was run by the French, who are great records keepers and so scientists. And they assessed the primary outcome at 6 months. And the rate of improvement in the arms was like stone cold identical. I think it was like 17% improved in the placebo and 17% improved in the hydroxychloroquine. It was like 17 or 23, it was one of those numbers. And so it didn't do anything. And then they did an open label extension phase from 6 months to 12 months. And they saw that like a bunch of people got better. And so they declared victory. But it's like 6 months in, nobody benefited. Nobody benefited from hydroxychloroquine. And so I use it sparingly. And the times when I use it is when someone has a good story for inflammatory arthritis. And I actually think that they might have seronegative rheumatoid arthritis, because those people might benefit from hydroxychloroquine. And so I'll use it if I think they have seronegative RA, but then I'll call them seronegative RA and I'll treat them for seronegative RA. A lot of seronegative RA people have secondary Sjogren's syndrome. And so that's a very plausible, relatively common presentation of Sjogren's syndrome that I would definitely treat those folks. Now, there's like 5% of people who have kind of gnarly Sjogren's syndrome. And these people actually have a very aggressive presentation. And they tend to have a couple features that distinguish them. One is that they have really high protein, like IgG is off the charts, like 2000 or something, like a ton of protein circulating around, lots of debilitating fatigue. They're the ones who more present with pericardial involvement. There's a lot of subclinical pericardial effusion in Sjogren's syndrome, but these folks present with like frank pericarditis. They often develop more of the neurologic sequelae, small fiber neuropathies and things like that. And those people I actually follow pretty closely. So I had a couple of patients that I would see regularly who had just very, very active inflammation from Sjogren's syndrome. And I followed them pretty regularly. Now, renal disease happens in Sjogren's syndrome. You can get RTAs, you can get interstitial nephritis, you can get a lot of frank renal disease from it. But it's not, it's like I have under 10% of people. Like there's just this enormous volume of people who have Sjogren's syndrome that's just sicca. And there's not a lot that we do. Yeah. It's a tough disease for people. It really affects them.
Interesting. Yeah. And another question that came up is the SSA antibody. Could you comment on how specific or sensitive of a test that is for Sjogren's?
Yeah, moderately. SSA antibodies have a reasonable. So I think in likelihood ratios. So so a sensitivity and specificity you can't really apply to clinical medicine, right? So if I say like, what does a sensitivity of 80% do for you? Like do you multiply by 80%, or is it 80% more likely? Like people have a hard time answering that question. I'm not going to make you answer, but how many people in the chat, raise your hand, could answer how you go from an 80% sensitivity to a clinical decision? Like, what do you need to do with that 80%? You don't have to answer. Just raise your hand if you can do it offhand. Yeah, see, it's hard, right? Most of us don't know what to do with that. The answer is you need to convert it to a likelihood ratio. Sensitivities and specificities are characteristics of the tests themselves. So they don't tell you what that test does for your patient in front of you. It tells you how good the test is in broad strokes. And because all clinical reasoning is Bayesian, you need to know how likely disease is before you apply a test. And then you need to use that test to influence and to get yourself a post-test probability. And the way you do that is with likelihood ratios. So if you have a sensitivity and specificity, you can calculate a likelihood ratio. It's not that hard. So the positive likelihood ratio is sensitivity over 1 minus the specificity. The negative likelihood ratio is 1 minus the sensitivity of 50. The negative likelihood ratio of an SSA is D.4, I think. I don't remember offhand. So it brings you down quite a bit. If you have a negative SSA, you probably don't have Sjogren's syndrome, but it exists. Then the positive likelihood ratio is pretty mediocre, depending on your lab. So my lab's pretty haphazard. And so there's a lot of positive SSAs in the low range that I don't think are meaningful, especially if people have a lot of other stuff going on. You give me a high SSA, though, then it's actually quite a bit better. And high SSA with the right clinical context is very strong and very useful. I actually say it often makes the diagnosis. So it's weird because it's not like there's a single answer. Give me like a good story and a high SSA, and I'll give you Sjogren's without doing a lip biopsy. If you give me like a mediocre story or bad story and a low SSA, I'm going to tell you it's completely irrelevant. So it's somewhere between completely irrelevant and clinching the case.
Yeah, no, definitely. It was a very helpful kind of discussion of sensitivity, specificities, and likelihood ratios, and how you can actually use how you need likelihood ratios in order to apply it directly to the patient. So that was really helpful. Pallavi mentioned the question. Oh, go ahead.
Yeah, to talk about this case, we haven't figured everything out. I'm still a little vexed by this one. So what happened to her platelets? Where'd they go? Did we ever figure that out?
Oh, I'm sorry. Her platelets were normal. It was.
Oh, they were normal. I thought her platelets were
1
low. Okay.
Oh, no. Did I mention that? No. I forgot to mention it. It was.
Okay. I missed that. I thought she had thrombocytopenia. All right. And then did you ever work up her hemoglobin? Why is her hemoglobin low?
Oh, she had macrocytic anemia, and her previous history was also significant for B12 deficiency, and she didn't complete her course of the B12 injections or the oral tablets, and she didn't follow up this time either for her prednisone and for her B12. But we don't know why it's B12. We suspected pernicious anemia only because it's not immune association, but we're not sure.
Did you send iron studies on her? Did you get iron studies?
No, we didn't get iron studies. We did get we did get the indices, and it was macrocytic.
Yeah, always get the iron studies.
I
mean, I see a lot of anemia of chronic disease, which tends to be microcytic, tends not to be macrocytic, obviously. But this stuff gets complicated. And there's just a lot of like kind of weird stuff going on with this patient. I don't like it. Oh, and someone shared a case report. I love it. There are lies, there's damn lies, and there's case reports. Do not ever use a case report for a clinical decision. Because so the truth is that everything under the sun has happened, and the presence of a case report is not a. I have strong feelings about case reports. So it's if you have to dig back to 1993 to find a case of that's like this, then if you just think about like the incidence of pernicious anemia and RTAs, I guarantee there have been thousands of those outside of the context of Sjogren's syndrome, right? Where they just happen to happen. And so this is the same point I had earlier, where it's like, whenever you have a rare disease and then you have to go back to 1993 to find your manifestations of said rare disease, it's like 30 years. Like you'd think that we'd have some stronger data by now about that, right? If this was like a common pernicious anemia. I mean, I've seen pernicious anemia in people without immune disease. It happens, but and it is immune to some. Yes, it's immune. Yeah, so I could see it, but you gotta be careful about that one. I ultimately think it was fair to chalk this up to Sjogren's syndrome. If she had dry eyes, she had a high SSA, she had a couple more things, but I would be very skeptical of it going forward. Like I would follow her in clinic, and I would never really feel good about that diagnosis until something else came up. Did you biopsy the kidneys? I'm assuming you didn't.
No, we didn't. She didn't follow up. And the left cheek swelling was it was a parotid swelling.
Mm-hmm.
So that, along with the SSA and the RTA, was so we presumed a diagnosis of Sjogren, but she didn't follow up ever after the emergency department episode.
Fair. We've been doing ultrasounds of these more. I don't do them myself because I don't want to get too much into Sjogren's syndrome. But people do these ultrasounds of these where they can say how echo dense it is, and they can see little silus, like little calcium deposits. And that would be a nice in-betweener, right? Where you don't need to biopsy anything. You can find a little bit of confirmatory evidence. But yeah, parotitis, I like that. Parotitis is a common Sjogren's presentation. All right, cool. That's all I got.
Yeah, no, I was just gonna ask. Well, I was gonna ask Sharanya if there was any follow-up, but it seems like unfortunately there wasn't much follow-up
Yeah, that'll get
information on the patient. But Dr. Putnam, I would love to just hear kind of any reflections you have about what it was like to discuss this case live and work through all this new data.
Yeah, it's fun. This was a good time. So, interestingly, as a consultant, I never see cases like this. I never see this because I never see people in the ER. No one walks into my clinic like this. And so it's funny, we don't really have people present with like our RTAs and no potassium. So this is kind of a fun experience for me, getting back to Gen Med. My patients present like this for a lot of other reasons. Like we see a lot of nerve involvement in autoimmune diseases. And so it's a very serious and you got to be ready to jump on it and really work them up quickly. Obviously, in this case, we got a lot of value from our basic labs, our Chem 7. That's why you always start with Chem 7 and CBC diff, because you can get a lot of value from that. And, once you see that her potassium is like negligible, then, you can cancel a whole lot of more exotic workup. But so kind of a cool case. This is fun. Thanks for having me.
Yeah, awesome. Well, Sharanya, I just wanted to pass the mic to you to see if you had any last updates on either the case or if you wanted to just share what it was like to present before jumping to Sammy for teaching points.
Yeah, like Dr. Putman said, I was, like when I saw this case, I did not think of an electrolyte abnormality at all. And I think everyone was confused as to how to work up this case until we saw the electrolytes, which made it a little easier for us because it was RTA right there. And I've never seen or heard of just potassium doing so much damage. And I was just thinking in terms of neurological pathologies the whole time. So this was very humbling for me too. But then again, like Dr. Putman said, it's pretty underwhelming, and we're not 100% sure either. But I just thought it's a pretty cool presentation and makes for a good discussion. And yeah, I learned a lot. Thank you so much. Dr. Putman was amazing. I just love how systematic all of this was.
Yeah, I think a lot of the time the process is much more important than getting the answer right, which I didn't. So, I think that's helpful. I think what you said there was really smart. I would give this patient a provisional diagnosis of Sjogren's because it does bring together most of the things. But caveat is that a lot of my diagnoses are provisional. And so I have a lot of patients, they just want me to tell them what they have. And I say, I can't tell you for sure. Like, I think you're in this spectrum, and the key to me is whether or not this gives us how to treat you, and that's at the end of the day, that's the most important thing, is being able to arrive at the right treatment, whether or not you have the right diagnosis exactly. So I think that being open to other possibilities and not prematurely closing, but ultimately saying, Sjogren's fits this better than anything else we can put together. So we'll kind of roll with it. It seems pretty reasonable to me.
Yeah, and I just want to thank you both. I think Sharanya, that you had it was such a fantastic case presentation. I mean, you had all the data there, and you really told it in a story where we were really, at the edge of our seats, wanting to know what was next. And Dr. Putman, I just want to, applaud you for you just really, even though this was a rare case and a rare presentation, you modeled so many clinical reasoning topics so well, from problem representation to having an anatomical approach to the weakness, and your kind of brilliant discussion on likelihood ratios. And I just want to thank you for your amazing discussion, and we can pass the mic to Sammy for teaching points.
Yeah, thanks for having me.
All right, thank you so much for this case, Sharanya. I really learned a lot, and Dr. Putman, amazing discussion, at least also how you discussed such an unfamiliar topic. I can imagine, as I said, you don't see this very often, but you still did very great, and I think we all learned a lot from you, so thank you so much for that. I will proceed to the teaching points. I'm really an acid-base nerd and electrolyte nerd, so I added some. But yeah, we start with the problem representation. which consists of the epidemiology. Dr. Putman told us this is a young patient, which is a little bit atypical, and we should always really think that there is a serious condition when a young person presents to the hospital. Then time and onset. Rheumatologic diseases usually have a slower onset and indolent, which also was atypical for this case. And the symptoms. Dr. Putman told us that predominant proximal weakness makes him think more about the myopathy. For example, poly or dermatomyositis versus distal weakness is more usual in a neuropathy. Then we had this topic of acute weakness, which can have many causes, for example, ischemic or inflammatory, for example, stroke, spinal ischemia, transverse myelitis, mono or polyneuritis multiplex, which I always think about as strokes to the small nerves and can also present sudden. And also AIDP, we should never forget that, versus metabolic causes, hypokalemia, hypophosphatemia, always important, especially if you have diffuse generalized acute weakness, always also think about electrolytes. Then we've talked about when a patient complains of weakness, it's important to distinguish between true weakness, which would point us more to a true neurologic deficit, versus asthenia, which is also present at rest and is seen in systemic diseases. Then we had this interesting finding of marked hypokalemia, which can be broken down to decreased intake, which is not that often seen, versus GI loss, for example, in diarrhea, vomiting, or laxatives, versus renal loss, for example, with diuretics, allosteronism, RTAs, tubulopathies, etc. And the most common seen thing is intracellular shifting, for example, insulin or beta-2 agonism. And it's very important when you have hypokalemia to always get urine electrolytes to see how the kidney is acting in this circumstance. I'm currently doing nephrology rotation, so that's why I'm all about electrolyte. So when we have a hypokalemia, that's actually something I learned from Uncle Bob. Always get the pH. If it's high, points more towards aldosterone excess. If it's normal, you have this rare entity of hypokalemic periodic paralysis, versus when it's low, most commonly diarrhea, but also renal tubular acidosis. Then we had this finding of elevated SSA antibody. Dr. Putman told us we should always get an ANA and the titer and get more further testing, because a lot of these rheumatologic panels can be falsely elevated and unspecific. All sorts of inflammations can do it, for example, endocarditis and bacteremia, etc. The workup of Sjogren's should always include SSA, SSB, ANA, rheumatoid factor, cryoglobulins, and if there is dyspnea or cough present, also pulmonary imaging, pulmonary function tests, lip biopsy only in selected cases, which was a very new teaching point for me, because they can also get numbness post-biopsy and it can impair quality of life. Renal manifestations of Sjogren's are mostly tubulointerstitial nephritis and rarely RTAs. And Dr. Putman also told us that more than 95% of people with Sjogren's complain of Zika symptoms, dry eyes, dry mouths, subacute to chronic, have arthralgias, myalgias, weight loss, fevers. So we should always think about that first. But I think the most important teaching points come now, that a rare presentation of a rare disease is very, very rare, and we should always take a step back and reconsider more common diagnoses, as Mr. Putman did, which is really important to do. And we should always consider atypical or typical presentations first before that. And it is very important how you label a diagnosis. And I have never got much clinical experience, but now I do. When I work in the hospital, start working in the hospital, it's so important to label something as a working diagnosis when you cannot be 100% certain, and not just a diagnosis, because the next physician will get your text and will think, yeah, that's like a settled diagnosis, and he will settle in it, and it will create premature closure and diagnostic mistakes. And that was a very important point raised by Dr. Putman. And yeah, thank you all so much for spending this time with us. I think we learned all so much. And yeah, thank you.
Sammy, those were such fantastic teaching points. You summarized the case so well, and then also added in just some gems, some electrolyte masterclass, and you just really highlighted the main points. So thank you everyone. Thank you, Sharanya. Thank you, Dr. Putman, and have a wonderful evening, everyone.
Thanks, everybody.